Welcome everyone to the Australian BioCommons AI in the Life Sciences webinar series. My name is Georgia. I'm the Australian BioCommons BioCloud Training and Communication Officer, and I will be your host for today. This webinar series is all about how artificial intelligence is being used in life sciences right now in real-world research. You'll hear directly from experts working across biology, medicine, agriculture, and environment as they share how AI is helping them and their research. Before we begin, we'd like to take a moment to acknowledge the traditional owners and their custodianship of the lands on which we meet today. In my case, this is the Gadigal people. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connection to country. We recognize their valuable contributions to Australian and global society. Today, we're thrilled to welcome Dr. Rebekah Harms and Dr. Yves St. James Aquino. We'll hear from both of them, and we'll have time for questions at the end of their presentations. We'll start with Rebekah. Rebekah is a postdoctoral fellow based at the Disability Innovation Institute at UNSW. Rebekah is undertaking a postdoctoral project which is jointly funded by the Critical Capabilities for Inclusive AI sub-project within the ARC Center of Excellence for Automated Decision-Making and Society and the CSIRO's Advanced Engineering Biology Future Science platform. This project aims to explore the barriers to achieving equitable use of AI and automated decision-making within engineering biology, and to identify practical ways of addressing these issues, particularly within the healthcare space. Welcome to the webinar, Rebekah.
I'm going to be talking today about the work that we've been doing around the uses of artificial intelligence in healthcare. So, as Georgia mentioned, this is a postdoctoral project which has been jointly funded by the Advanced Engineering Biology Future Science platform at the CSIRO, as well as the Centre of Excellence for Automated Decision-Making and Society. And so the team for this project is myself, Professor Jackie Leach-Scully at UNSW, Professor Rachel Ankeny at Wageningen University in the Netherlands, and Dr. Aditi Mankad and Dr. Lucy Carter, both at CSIRO. So as part of our project, we're looking at the way in which artificial intelligence is being used in healthcare. And specifically, we're interested in the way that AI is currently being used and will be used in the field of engineering biology. So for those who are not familiar with the term, engineering biology is a field of research which is closely related to synthetic biology. It can be considered a more applied version of synthetic biology. It's also been defined as the design, scaling, and commercialization of biology-derived products and services that can transform sectors or produce existing products more sustainably. So artificial intelligence offers many benefits to the field of engineering biology. So it can be used to analyze large quantities of data. It can enable researchers to predict biological functions. It can help streamline drug development, and it can be used to deliver more personalized forms of medicine than we currently have access to. But although AI poses enormous benefits to engineering biology and to healthcare in general, there are potential downsides to using AI technologies. So AI-based products have been shown to produce biased results, as one example. So bias can emerge at any stage during the development of an algorithm. It can emerge during data collection. So often the data on which algorithms are designed are not representative of diverse demographic factors, or the algorithms may be used on populations that it wasn't trained on, which can lead to inaccuracies. Bias can also be seen in the way that algorithms are designed. So for example, a lack of diversity in the teams that design an algorithm can then lead to biased design choices. Those who label the data, so in other words, those who assign meaning to the data for the algorithm to then interpret, can also label the data differently depending on their own knowledge or preferences. And finally, bias can arise when algorithms are actually being used. So for example, practitioners who use these algorithms may become either overly reliant or overly skeptical of an algorithm. So there are a whole range of ways in which algorithms can have inaccurate outcomes or are unable to perform equally between different groups. Because of this, it's important that AI tools are used responsibly and that any potentially harmful biases are minimized. And I specifically mention harmful bias here because there may be some cases where it might actually be preferable for an algorithm to treat patients differently depending on their individual circumstances. But generally speaking, we should be seeking to minimize bias as much as possible and ensuring that these tools are being used responsibly. So to explore more about these issues, we conducted a systematic literature review exploring bias mitigation strategies aimed at the developers of AI algorithms. As part of this literature review, we conducted a search on the Scopus and Web of Science databases for relevant articles over the past 10 years. The search string, which you can see here, captured those articles which referred to artificial intelligence in healthcare and discussed at least one of the keywords that you can see listed here. So it's things like bias, equity, fairness, and justice. This search resulted in over 8,000 articles, which were screened by title and abstract, which was then cut down to almost 2,000 articles, which were screened for inclusion in the review. So only those articles which provided specific bias mitigation strategies for AI developers were included. And by AI developer, I just mean anyone that's involved in the design of an algorithm. So sometimes in the literature, this is referred to as a development team or even just a researcher. But these people are performing similar functions, which is basically to prepare the data, construct an algorithm, evaluate the algorithm, and then eventually to review the model once it's been deployed in a clinical setting. And you'll notice also in this search that we didn't specifically limit the articles to engineering biology. This is because when we were testing out different search strings, we found that there were very few articles which focused on AI bias around engineering biology or even related fields like synthetic biology. So for this reason, what we decided to do is basically keep the review somewhat broad in capturing any kind of medical field, but then we used these findings to extrapolate back to the field of engineering biology. So what we found from the 51 articles which were included in the review was that bias mitigation strategies tended to be grouped around 7 key themes. One of these was around the importance of having diverse development teams. So many articles argued that there should be a diverse range of individuals who are responsible for designing an algorithm. So that could be from a demographic perspective, or it could be from drawing on a diverse range of expertise from different fields. Others argued that developers needed more training and education on bias mitigation. The third theme was around awareness and responsibility. So quite a few articles believed that the onus was actually on the developers to be aware of potential sources of bias and to be reflexive about their design choices. Another common theme was the importance of diverse data. So many argued that developers must ensure that the data sets they use to train the algorithm are representative of a diverse range of populations, including those who are typically underrepresented in existing data sets. The fifth theme was around collaboration with end users and beneficiaries. So many articles argued that it's important for developers to work closely with end users, so like clinicians, and the beneficiaries of these algorithms to ensure that a diverse range of perspectives are taken into account. And having input from these stakeholders can, it's argued, help identify a broader range of potential biases. The final 2 themes which you'll see here are around monitoring and evaluation and transparency. So many articles argued that developers should be regularly monitoring algorithms to assess their performance during both the design and implementation stages. And transparency was also seen as an important attribute. So several argued that developers should be transparent about whether their algorithms perform equally among different populations and disclose any limitations. So while all of these recommendations are valuable, very few of the articles we reviewed provided empirical evidence about the effectiveness of these strategies, or even provided practical guidance about how these strategies could be implemented in a real-world setting. So we found that only 18% of the articles we reviewed were based on some kind of empirical evidence. The rest were speaking from a theoretical perspective. We also noticed that there was a skew in terms of the focus of these articles. The majority of the articles we reviewed wrote about AI from a general perspective rather than from the perspective of a particular field of medicine. So in this case, it was 63% of the articles which were generalist in nature. And on top of this, none of the articles we reviewed talked about how AI is being used in engineering biology or in any similar type of field. So because of this largely theoretical and generalist type research, it's difficult to know how bias mitigation strategies can be operationalized within particular fields. And ultimately, what we argue is that more research is needed to test the practicality of bias mitigation strategies across different scientific fields and across different geographical contexts. So it's because of this lack of information on engineering biology that we decided to move on to the next stage of our project, which is the stakeholder interviews that we've been conducting over the past month or two. So in order to gain a better understanding of how researchers in engineering biology are using AI and what strategies are best suited to help them prevent bias when using these tools, we've decided to conduct a number of interviews with stakeholders along the AI development pipeline. So this includes scientists who are using AI in their work. It also includes AI developers who have expertise in designing algorithms, healthcare practitioners who may be using these technologies to treat patients, any people working in industry who may be commercializing these tools or offering their services as AI experts, ethics policymakers, so anyone that has insight into the regulatory or ethical oversight of these technologies, and finally, representatives of the databases that AI tools are being used on. And I should also note here that we're targeting people who work in similar types of fields to engineering biology or who use similar types of techniques. So that's things like synthetic biology, genomics, or any other kind of omics analysis, structural biology, and so on. So far, we've conducted 9 interviews, and I think I can say fairly confidently that even just with these set of interviews, we've been able to see some emerging patterns in the way people use these tools and how they think about the ethical challenges of using AI technology. And even with these initial set of interviews, it's becoming clearer to us that there is indeed something unique about the engineering biology space, which warrants closer scrutiny. So from the discussions we've had so far, it's clear to see that AI has already become a central part of the way that researchers are doing their work. Many of the people that we've talked to have spoken about using AI in their day-to-day work for things like polishing their writing, finding literature, writing code, helping with grant writing, and just generally helping generate ideas. So we're considering these types of tasks as routine uses of AI, which take advantage of the range of generative AI tools currently available. So this is things like ChatGPT, Copilot, Gemini, and Perplexity. Generally speaking, participants tended to talk about the inaccuracies of these tools rather than the potential for bias. So many people spoke about having to check the outputs from these generative AI tools to make sure that they were accurate. And in particular, the literature searching capabilities of these tools was a particularly problematic area. So we heard from some people that these tools were generating false sources. But AI is not just being used for these routine tasks, it's also being used to facilitate research. And again, I should note here that we've specifically been trying to talk to people who've publicly said that they use AI in their work. So there will be a bit of a skew in our sample towards those people who have already begun to incorporate AI into their work. But among our participants, AI is being used to model biological phenomena and for disease classification. A few have also said that they're using AI for protein folding and binding, as well as protein design. And for these types of uses, our participants are using machine learning. So that's things like AlphaFold. Predictably, what we've heard so far is that the key value of AI, both in terms of the routine tasks, but as well as the more specialized research work, is its ability to improve productivity. So whether that's saving time, streamlining the scientific process, or helping to sift through large quantities of data. This is not to say, though, that everyone views AI in a positive light. So we asked people whether or not they had any concerns about the ethical issues associated with the use of AI, or whether they worried about its accuracy. Again, we heard from people that there were some concerns about the accuracy of the generative AI tools. But with the machine learning tools, one of the key things we've been hearing is that the data sets on which our participants are applying the AI tools are limited, and they may not actually represent a wide range of demographic factors, which can then in turn impact the accuracy and generalizability of the algorithm. And this is not something that's specific to AI. The lack of data on diverse populations is a common problem that's well known in the biomedical field. but it is continuing to be a key challenge with the use of AI. There was some discussion of other types of bias, including around the male dominance within computer science. And we also heard some concerns about the issue of privacy. So this was particularly around inputting people's data into these AI programs. But I would say, generally speaking, we haven't really heard our participants discuss the wide range of ethical concerns that we know can arise when using AI tools. We, of course, need to do more interviews to see whether this is a pattern, but if the trend does continue in this way, it might suggest that researchers are aware of some types of ethical issues or biases, but not as aware of others. So despite the potential drawbacks of using AI technologies, some of the scientists we talked to didn't really see AI as being particularly special. They believe that AI is just like any other kind of tool that's used in science. In other words, it's up to the scientists to use their critical thinking skills when using any tools, not just the AI ones. So this was the typical, it's just like a calculator type response. In line with this, a common thread among those we've talked to is that humans still have a vital role to play despite the increasing sophistication of AI tools. So nobody we've talked to so far is anticipating a time where AI will take over completely and there won't be a need for human intervention. We've also heard that it's important for humans to continue monitoring the AI outputs to ensure that they're accurate. And some that we've talked to have even been worried that too much reliance on AI might cause them to lose their skills or limit their creativity. One final thing to note about the interviews has been the relative lack of guidelines around using AI. So during the interviews, we've been asking participants whether there are any guidelines or steps they must follow in order to incorporate AI into their work. And people have generally been saying that there actually aren't any restrictions on the use of AI, other than perhaps the costs of purchasing some of these tools. But generally speaking, the only real guidelines that we've been hearing people follow is around privacy and ensuring that sensitive personal data is not inputted into AI programs. We still have more interviews to conduct, including with regulators and policymakers who may have more to tell us about whether any guidelines are being developed around the responsible use of AI tools in the engineering biology space. But this is an interesting finding from our admittedly limited interviews so far and suggests that more could be done to develop a set of best practice guidelines around using AI in these types of fields. So as I said, we still have several of these interviews to conduct, which we'll be doing over the next few months. And hopefully the findings from these interviews will enable us to not only capture the current landscape of AI use in engineering biology, but will help us come up with some recommendations for ways that scientists and the field as a whole can tackle the ethical issues posed by AI. And one final thing I wanted to add is about the difference between engineering biology and other fields when it comes to the use of AI. So I think it comes down, at least in part, to the fact that uses of AI in these fields, from what we're hearing so far, tends to be for research that is more speculative in nature. So the scientists we've talked to are tending to use AI for basic research rather than developing an algorithm that will be used in a clinical setting. I think there are other things that we'll be able to point to as we progress with the interviews that sets engineering biology apart, but this is at least one area where we can point to the specific qualities of engineering biology as having influenced the way people use AI, and in turn, how they view the ethical challenges associated with using these tools. This is not to say that the ethical challenges of AI are non-existent in engineering biology, but it does suggest that we need to think in a more nuanced way about how those bias mitigation strategies that I mentioned earlier can be adapted to specific fields of research, taking into account the unique ways in which research is conducted in different fields. So I'll leave it there. Thanks for listening, and I'm happy to answer any questions in the Q&A portion, or please feel free to get in touch if you want to hear more about our research. Thanks.
So Yves is a physician and philosopher with expertise in theoretical and applied ethics, empirical bioethics, and philosophy of medicine. His program of research currently focuses on the ethical, legal, and social implications of AI applications in healthcare. Yves is a research fellow at University of Wollongong's Australian Centre for Health Engagement, Evidence and Values, and a member of Wiser Healthcare, a multi-institutional collaboration conducting research that will reduce overdiagnosis and overtreatment in Australia and around the world. It is also one of the editor-in-chief of Research Ethics. Welcome to the webinar, Yves.
I'd also like to thank Georgia for inviting me and for the Australian BioCommons for this opportunity. For today, I'll talk about data equity and the challenges of diversifying datasets for healthcare artificial intelligence. And my presentation is based on the program of research we conduct here at the Australian Centre for Health Engagement, Evidence and Values. We use empirical bioethics methods to examine the ethical, legal, and social issues in using AI and big data for healthcare applications, including healthcare service provision and healthcare research. I'll first talk about the challenge of diversifying datasets, and then I'll discuss some preliminary insights from a scoping review of policy documents, and then share some useful resources that might interest the audience. So about algorithmic bias, Rebecca already discussed quite comprehensively the problem of algorithmic bias in healthcare, but I'll like to reiterate where the problem lies when it comes to healthcare applications of AI. Um, as Rebecca discussed, algorithmic bias is a serious problem in AI and big data broadly across different sectors and applications. And the image on this slide shows that algorithmic bias feeds into and is fueled by existing cycle of inequities. So if you look at the upper left quadrant, you see here real world patterns of health inequality and discrimination that involves unequal access and resource allocation. So some individuals or groups may not have access to healthcare resources. There are also discriminatory healthcare processes and practices where individuals or groups are not provided care or not provided quality care based on their identities. There could also be biased clinical decision making where healthcare practitioners, because of their prejudice, might not provide care or might not provide quality care for different groups or individuals. And then if you look at the upper right corner, sorry, discriminatory data. I'll explore this further in the next slide, but here you have sampling biases and lack of representativeness in datasets. You also have patterns of bias and historical discrimination embedded or encoded into the datasets. And then on the lower right quadrant, you have bias AI design and deployment practices. Due to power imbalances in agenda setting and problem formulation, you have biased and exclusionary design that leads to application injustices. Here you have deepening digital divides, exacerbation of health inequality, and then you also have hazardous and discriminatory purposing of biased AI systems. And these application injustices fuel back into real world patterns of health inequality and discrimination. Focusing on the problem of data, data inequity describes the unequal distribution of data and unequal outcomes resulting from its use. And there are different dimensions or types of inequities. You have data inequity that can arise when there is poor representation of groups or individuals in data sets. So usually information or data from marginalized groups or individuals subject to prejudice are usually not represented in datasets. Inequity can also arise when, even if there is sufficient representation, the quality of the data may be different. So there are a lot of studies, for example, in imaging datasets. These studies have shown that medical imaging in under-resourced communities are of lower quality in terms of pixelation and in terms of interpretation of these images. Third type or dimension, even with same resources, or same with the resources, there might be inequity in infrastructures that collect, manage, or provide access and share data. And fourth type or dimension is that inequity can arise when outcomes differ, when outcomes of technologies that use these inequitable data sets also result in an inequitable outcomes. Um, as Rebekah discussed, there are a lot of solutions published in literature, and most of these solutions or mitigation strategies look like this. You have mitigation strategies across AI life cycle. Uh, a lot of these proposed frameworks claim that there are various opportunities where we can intervene. It usually involves broad guidance statements that are quite hand wavy. For example, in the image, you have guidance principle 1, which is to promote health and healthcare equity during all phases of the healthcare algorithm life cycle. This is a good start, but the real challenge is translating what this means on the ground or in practice, which is not very easy. And because of these kinds of broad mitigation strategies or solutions, we wanted to further explore what experts think of algorithmic bias and what are the best strategies to address it, similar to what Rebekah is doing now with their interview study. To do this, our team conducted an interview study with participants from diverse groups of expertise involved in AI development, as well as other professionals involved in the acquisition, implementation, and regulation of artificial intelligence. All in all, we had 72 participants. I could speak more about the methods during the Q&A if people are interested, but one of the key findings I'd like to highlight is the disagreement among experts about the role of sociocultural identities. So these are identities or information about race, ethnicity, gender identity, socioeconomic status, and other cultural identifiers when it comes to addressing algorithmic bias. So based on our findings with the question, should datasets include information about sociocultural identities, we had three contrasting views from our participants. In one extreme, we referred to this as the exclusionary view. So these participants believed that sociocultural identities should be excluded from datasets or from developing artificial intelligence. And they provided a couple of reasons. One is that they wanted to prevent the risk of assigning disproportionate weight to different kinds of identifiers or identities. They also believe that some sociocultural information, for example, religion or race or ethnicity, has no impact on disease and progression of disease or diagnosis of disease. Of course, this is not entirely correct. There are situations when one's social identity impacts on their health outcome and even the prognosis and progress of the disease. The other extreme is the inclusionary view. So this is where participants believe that sociocultural identities or identifiers should be included and collected when it comes to data sets that are used to train artificial intelligence systems. Some of the reasons provided is to increase diversity and representativeness in data sets, one of the key mechanisms to address algorithmic bias. Another reason is to enable healthcare systems to identify underserved groups, and that could instigate different actions, including ensuring that these underserved groups are served and provided healthcare services, but also their information can be collected in order to ensure datasets are representative. Some of our participants, while they believe or they are aligned with the inclusionary view, are concerned about increasing surveillance or the risk of increasing surveillance, especially for minority groups that are already highly surveilled. This is particularly important or salient in the context of policing and criminal justice. So some minority groups are already over-policed, and when you include their information, it might increase this kind of surveillance. A lot of our participants held the uncertain view. So this is where they feel that the question is too complex for them to provide a position whether to include or exclude. And some of the reasons provided by these participants, a lot of them believe that sociocultural identities and data involve fuzzy categories, and they believe that artificial intelligence and data science prefer discrete categories. So if you talk about, for example, gender identity or racial identity, um, several identities can exist at once, or these identities exist in a spectrum. Some of the participants also thought that some sociocultural data are too sensitive and require self-identification, which is not as reliable. And some of our participants also thought that sociocultural data are just too complex, that it's hard to convert them into data points that are useful for developing algorithms. In order to explore this complex challenge, we wanted to investigate what are the current guidance from different policy documents across different jurisdictions. So we conducted a scoping review of policy documents, which we started last year. Um, we wanted to focus not on peer-reviewed literature, but on gray literature, and these include policy guidelines, policy reports, legislations, and guidance documents. And we wanted to focus on documents where there is a clear jurisdiction or the authoring organization has some policy power or policymaking influence. We wanted to look at recommendations to ensure equitable representation of socially constructed categories of difference. So this is a mouthful, but this is what the way we are labeling social categories or sociocultural identifiers. In terms of jurisdictions, we included Australia, New Zealand, United Kingdom, Australia, Canada, and United States. We wanted to focus on multicultural countries where AI development and deployment are happening. We also wanted to include intergovernmental documents authored by the OECD, by the EU, and by WHO or United Nations. In terms of period, we included documents published inclusive between 2010 and 2025. Our research question is, how do policy documents operationalize, define, and classify socially constructed categories of difference, i.e. race, ethnicity, sex, or gender, to ensure data equity in the development of AI for clinical applications? Based on our preliminary findings, we found at least 4 challenges. First is the lack of consensus on whether to collect information about social categories of difference. So some documents advise collecting and documenting these information, but making sure that these information are de-identified. But some documents actually disagree and say that we shouldn't collect information that might increase the likelihood of prejudice. The second challenge is the lack of standardized definitions or classifications of social categories. So different countries in the included jurisdictions have different ways of defining, for example, aboriginality, indigeneity, or race. The third problem is what to do with proxy variables. So this is a problem when an algorithm can still have an adverse effect on vulnerable populations, even without explicitly including protected characteristics. And these occur when a model includes features that are correlated with these characteristics. For example, language spoken at home can be proxy for race. Names can be proxy for gender and race. So even if you don't collect information about racial identity or gender identity, sometimes name or names can be a proxy with these information or for these information. The fourth challenge is the lack of guidance on how to incorporate intersectionality. So intersectionality is a framework of understanding the ways in which different aspects of a person's identity can expose them to overlapping forms of discrimination. So gender identity can intersect with racial identity, and discriminatory experience can be amplified when you have a combination of different kinds of identities. For the interest of time, I'll focus on the issue of lack of standardized definitions or classifications of social categories and provide some examples. So here is an example from the Australian Commission of Safety and Quality in Healthcare. And this guidance relies on self-identification when it comes to classification or definition of social categories. So the guidance here when collecting information about Aboriginal and Torres Strait Islander status, following question according to the document should be asked of all patients when commencing with a health service. Are you or is the person of Aboriginal or Torres Strait Islander origin? So this shows number one, when something is mandatory. So here, uh, cla collecting information about Aboriginal and Torres Strait Islander status is a mandatory guidance. And this document also shows reliance on self-identification. So they don't really provide a definition, and they don't, so the process does not involve the person collecting the information to rely on an external definition. What they're relying on is the patient or the health consumer providing the information themselves. Another example is from the US. Again, this one, all health related data collections are mandated to conform to the US Office of Management and Budget's government-wide standard called Statistical Policy Directive number 15. So here, you have the question, what is your race and or ethnicity? And there is an opportunity to actually select at least more than one race and or ethnicity. They do provide some examples for each category, although they do not provide specific definitions. Again, what this is indicating is that this document or guidance relies on self-identification. And translating challenges into opportunities, we propose the following. First is to develop consensus and establish clear policies on the collection of information about social categories. Second, to uphold, refine, or develop standards for defining, classifying, and labeling social categories. Third is to identify strategies on how to manage proxy variables. And third, to do or commit to interdisciplinary work that is needed to understand intersectionality and how multiple identities should be taken into account. Before I end, I would like to share some resources that might be useful for members of the audience. The first one is a 2020 technical report from the Australian Human Rights Commission. It provides broad overview of AI bias across applications and industries. The recommendations are on the level of organizations and companies, but not individuals. Another resource is a guide that we developed here at the Australian Centre for Health Engagement, Evidence and Values. And this guide provides consumers and consumer representatives with an introduction to AI in healthcare. So increasingly, community and consumer representatives are being asked to be part of consumer panels to provide advice for different research groups, especially in universities. or publicly funded grants. So we wanted to create a resource that's easily accessible, and this was developed with a consumer reference group or consumer panel consisting of 12 experienced consumer representatives. This was led by Jennifer Morris, who is a safety professional and healthcare consumer representative as well. And finally, watch this space. Our team had a successful grant application. The grant or the project is called Rep.ai Plus project. This is an NHMRC partnership project, and it aims to develop resources for the ethics review and research governance of AI-related research. And our partner organizations include the Australian Institute of Digital Health, Alfred Health, New South Wales Health, Bellbury Limited, which is a not-for-profit organization providing ethics review of research, any kind of research involving human participants. We also have Researchers Australia, Population Health Research Network, and Medical Technology Association of Australia. Thank you so much. I'm looking forward to comments, questions, and our discussion. Thank you.
So it's for both of you. Rebekah, you mentioned how there is a lack of guidelines, and Yves, you mentioned the disagreement that you can notice among experts, and you've both shown that there are some kind of resources here and there, but since the AI field is continuously changing, do you foresee actually Australia having a kind of a guideline for use of AI, and do you think researcher would follow it, and how would that be regulated?
Sure. As you were speaking there, I'm recalling some of the interviews I've done with people, and I'll ask them, "Are you interested in guidelines or regulations?" And some people will say it might just be a kind of checkbox type of exercise, and it doesn't really have any teeth. And so some people are saying could just contribute, having guidelines that you have to follow might just contribute to yet another thing that you have to do where you have to fill in forms. And so some of them were not necessarily saying they were hesitant about having guidelines, but some were sort of saying, that it might end up wasting time and may not be as much use in that sense. And even two people would say to me, like, there's a bit of a lack of connection, I guess, between the people that are doing the science and the people that are making the regulations. So I would hear people say, the people that are developing regulations might have a legal perspective, but they don't necessarily have a scientific perspective. And so what the legal experts think is relevant may not actually be relevant to the scientists. So that's all to say there are, I think, some challenges around how we are going to develop any kind of ethical guidelines or regulations. But I will say that, people are still receptive. So the interviews I've done so far, people are still saying, look, it would be helpful if we could have some guidelines, particularly around things like which types of AI programs should I be using? What are the pros and cons of using different types of tools? Can I use a particular tool to commercialize? Or, I guess there's a whole range of different questions that I think scientists have when they go and use these tools, particularly considering a lot of them might not actually be AI experts. And so I think there's some receptiveness to that kind of thing. I think there still would be some receptiveness to general ethical guidelines, but I think it is important to note that there are still some hesitancy, I think, from the part of scientists to yet another kind of checkbox exercise that maybe won't actually influence how they do their work.
Yep. Thanks for the question, Georgia. I think one misconception that I'd like to get corrected is that AI regulation, there's no AI regulation. There are a lot of AI regulation, but it exists in different parts. If you look at AI applications in healthcare, we have to understand that AI is just another technology that will be regulated if it will be used in healthcare research or practice. And healthcare is highly regulated. So even if you don't have a law that says AI cannot discriminate. There are a lot of laws that say you shouldn't discriminate. So in healthcare practice, you cannot discriminate based on any kind of social identity in providing healthcare. When it comes to medical device, that's regulated through medical device regulation. Consumers are protected through consumer laws. So it's really understanding what kinds of regulation exist and which ones you should really comply to. When it comes to health research, of course, you have research ethics committees, and you have site-specific assessments. So there's a lot of research governance that exists. It's a matter of educating people. So especially with the AI community, not a lot of them are used to these kinds of regulations. Medical device technology companies are used to going through reviews, doing clinical trials, providing evidence. Same with pharmaceutical companies. But when it comes to AI companies, they don't know. They actually have to go through regulation, and they think that they are not subject to it, even if they are. So it's really a matter of educating people that a lot of laws exist and a lot of guidance exists. And guidance can also occur in different levels. So you have Australia, for example, the Australian government has released a document on safe and responsible use of AI. Professional organizations also provide guidance. Specific companies might have their own ethics, but one thing is clear based on a lot of studies: self-regulation is not effective. So we do have to highlight what external sanctions exist for organizations or individuals who do not comply with the law. Yep.
Thank you. And in terms of educating people, what other methods do you think might encourage people to, adapt to this kind of guidelines and rules and address potential biases?
That I think this idea of co-production is something that's really interesting, and we want to look more into that in our project. And I think, speaking to people, they'll often say that they want to develop things that are clinically relevant. And so they, at least those people who are working with clinicians, they'll, work closely with the clinician to make sure that what they're developing is actually relevant. And so I think more of this would be useful. I think, as Yves was saying, around the consumer groups. I think having more of this co-production, different stakeholders, end users, beneficiaries working closely with the scientists to make sure that they're developing these tools in a responsible manner, I think would be very helpful.
For me, I think the interdisciplinary collaboration, including consumer engagement and community engagement, I think interdisciplinary collaboration is really important, and that includes lived expertise. Uh, a lot of scientists or AI developers who are not familiar with clinical practice or just healthcare in general may not be familiar with existing inequities in terms of health outcomes, in terms of availability of data. For example, a lot of AI systems are really built for adult population. They're not built for pediatric population. And one of the primary reason is that pediatric data is much more protected, and data collection of and management of pediatric data is much more complex. A lot of privacy obligations are much, much stricter compared to adult patients. But also that pediatric data is just not as available when it comes to public data sets. There are a lot of medical conditions where there are existing inequities based on gender. For example, a lot of cardiovascular conditions, health outcomes are poor when it comes to women. And in some medical conditions, so there are a lot of problems of representativeness in data sets, and not just for data sets used for AI development, but just data in general, like clinical trials, because of the history of exclusion of women and exclusion of some groups based on race, even gender diverse information not being available. A lot of clinical trials are biased towards certain groups. And these studies are influencing clinical practice. So there are a lot of inequalities and inequities that are embedded in healthcare practice. And being aware of that is really important. So yeah, so I think interdisciplinary collaboration and collaborating with people who are working on the ground and having lived experience, I think that's part and parcel when it comes to developing AI.
Where do you think Australia is lagging when it comes to issues around responsible use of AI?
Oh,
Yeah.
I think for me, it's something around the data. So I'm hearing from people often when I talk to them that they'll say the data is quite limited, or there's issues around privacy with how we deal with people's data. And so for me, I would say I think with the increasing discussion around having the sovereign AI capability in Australia, I think that data piece is really important because not only are there the kind of privacy concerns around how we're handling people's personal data, but I think there's also a potential there. I think there's the potential for Australia to really improve the data sets that people can use to build these, to train these AI models. So, and obviously doing so, then we can hope to address some of these challenges that we've been speaking about throughout the webinar. So for me, I think it would be something around the data, how we're going to be sharing that data, and how do we protect people's privacy.
It's difficult to solve inequities. Is there a way that we can ethically and safely develop AI systems that rely on inequitable data?
Yeah. We hear this a lot from AI developers that say it's really outside of their control when it comes to solving real world injustices. Is there a way for them to still be able to develop AI knowing that data will always be inequitable and will always be unrepresentative? I think one way to deal with this is yes, you can still develop AI, but you do have to be transparent when it comes to the limitations of your algorithm. So that means being transparent about the kinds of populations included in the data sets that are used to train and test your algorithm or your AI system. And then being transparent about that and stating where it cannot be applied. Um, and then identifying opportunities where you could increase that representativeness. I think just being honest that AI is imperfect. A lot of marketing is really trying to sell you a tool without clarifying that it's not for everyone. And we know this to be true with a lot of medical technologies, but now, especially in medical devices, we we already have a system in place to say what populations are going to be where you have to specify which populations this medication or medical device should be used upon, right? So if it's for adult population, you have to state that. If it's not for pediatric population, then you have to state that as well. So it's still imperfect within the healthcare system and medical device regulation, but we do have a system in place, being transparent about the limitations of your technology.
Thank you, Yves. We have to leave it here for today. Thanks to both of you again for joining. You can find out more about the upcoming webinars, workshops, and other events on our website and watch recordings of this and previous events on our YouTube channel. And finally, we'd like to acknowledge our funding. The Australian BioCommons is enabled by and increased by Bioplatforms Australia. Thanks so much again for watching, and we hope you enjoyed today's presentation. We look forward to see you again soon, and until next time, goodbye for now.